privileged and honored to interview Dr. Little, a great surgeon, and we'll talk about that in a little bit, but I just wanted to say thank you for coming.
Well, it's my honor, David.
Thank you. Well, it starts out simple. State your full name and date of birth.
Well, I'm John William Little III, and I was born March the 12th of 1944. Now, I'm Dr. John William Little III, meaning my grandfather was Dr. John William Little Sr. My father was Dr. John William Little Jr., so I really am the third, but of course I'm the only one surviving.
Okay. What field of medicine were they in?
Well, my granddad was an old-fashioned family doctor, and my dad was a radiologist, and here I am, a plastic surgeon.
Okay. So they encouraged you to go into medicine, or you decided
Well, they
on your
did
own?
in a sense, but I didn't feel pressure. That was sort of my feeling. I'd lived with medicine, growing up with them, and I wanted to be a doctor, but my inclination was towards surgery, more as a more directly active involvement in healthcare. You know, you can see your results for the good or the bad.
Yes.
And they're pretty direct and all that. And then art was always sort of a second theme in my life, so plastic surgery was a natural choice for me. And when I say art, I don't just mean visual art, which has been. I love visual art. I admire the great artists of the world, but I majored in performance art. I was a music major in college before I went into that long slog we call medical school.
And where'd you go to college?
Dartmouth.
Okay.
They had a good music department, small.
Okay.
I enjoyed it.
Super. But were you pre-med then, or did you go in?
Yeah, I was I'd always been pre-med. I made my decision to go into medicine when I was in high school, really. I was committed to the idea then. And I was committed also to the idea of plastic surgery in high school, so I was a little unusual then. So many of us, you know, make our choice for plastic out in our general surgical years
Right.
and all of that sort of thing, but I made mine early.
Okay. Now, your mother's name, I didn't ask you that.
Yeah, Nida Jones. And, Nida Jones.
Okay.
Unusual name.
And how many children do you have, grandchildren?
There are none so far as I know.
Okay, children or grandchildren?
None. But I enjoy my wife's children and grandchildren. They're very close to me now and my family, but I have no offspring of my own.
And how did you meet your wife?
Well, now there's I don't know whether I should mention or not. You ask in some of these things you alluded to before in preparation for this, is there any connection with you? Well, no, not with my current wife, but my first wife. She happened to be the eldest granddaughter of Earl Paget, and we all know that
Yes.
great contributor from Kansas City and all. And I must say that my meeting Patsy by chance in Aspen, Colorado, when we were both in high school, maybe spurred me to look more closely at plastic surgery as an option. And our marriage didn't survive, unfortunately. And I'm happy to say that I'm married to the love of my life right now, Kathy, who I met about 12 years ago.
Okay. So plastic surgery then you feel might have been stimulated from some relationship with the Pageant family.
She was proud of her granddad, and she was his favorite by far. And she told me a lot of stories about it. And in high school, we were both in preparatory schools, so-called. And I started delving into plastic surgery more, with more interest, with that sort of a spur from her.
Okay. Any specific mentors you want to mention while we're on the subject?
Well, I've been lucky. You know, we've all been lucky, haven't we, that people took the time to want to train us and educate us. And I might be alone in this. I did 2 residencies in plastic surgery, and I didn't do the second one because I failed at the first one. I did it because I was a little bit ahead of schedule in my thinking about things. And this was back in the days where we didn't have all these wonderful fellowships we have now, and they were few and far between. And I just decided this, because I found myself about 3 or 4 years ahead for various reasons of where I'd expected to be. So I decided to immerse myself in a second residency, and I did that with Ralph Millard Jr. That. So you ask my prior mentor, Clifford Keene, was probably the finest surgeon I ever met in terms of technical skills, and I'm including in that my thoughts about Ralph Millard. Clifford Keene was just a surgeon's surgeon, but his focus was on head neck extirpation and its reconstruction, right. And he wasn't particularly interested in aesthetic things, but he was a absolute gem of a surgeon from a technical point of view, and I had a great fondness and a long relationship with him until the time of his death. But Ralph Millard was a different thing altogether. Now, both of them had been influenced by a guy by the name of Harold Gillies,
sure.
that you know very well. Of course, Millard, as we all know, spent a couple of years over there in his early training. Keene went over there later in his war years, but he was heavily influenced by Gillies also, not to the degree that Millard was. So this was a common theme in both. But Ralph Millard, for me, was my formative mentor, and a man who was widely recognized, widely appreciated, but perhaps somewhat misunderstood, not always as beloved as some of his trainees thought he deserved to be. But he was, to me, a man who was true to his principles to the very end of his career, and in a way that was almost unique in plastic surgery. And he taught me so much about the broad horizon of this specialty. So those of us who trained with him consider ourselves lucky. Well, and he's my special mentor.
And I'd say that he was a perfect combination of right and left brain. The book Cleft-Craft, which won the Pulitzer, and I have that. I got rid of a lot of books as I pared down, but that one I'm keeping. I don't know what I'm going to do with it because my kids wouldn't probably appreciate it. What a beautifully written book,
it was,
documentation.
But he offended a lot of people writing it, and that was his nature, and that was his style. And I'm not going to make any comparisons, even though we're in New York City with Donald Trump, but he offended a lot of people, Dr. Millard did, but he did from a principled point of view, and he spoke the truth. And beyond that, I'm not going to make parallels because I'm not a particular fan of Donald Trump, but I'm a big fan of Ralph Millard. But he was a unique figure in his time, and he just brought plastic surgery to a new level that was not based on technical concepts or technical principles, but on philosophical principles and broader principles. And a lot of them were wrapped up in art. And you mentioned the right brain, left brain. His brother was an artist. He earned his living painting. So there was that gene in the family somewhere. And a lot of that comes out in his oeuvre and his work.
Okay, you see momentous paradigm shifts in plastic surgery
Sure.
in your illustrious career. Just tell me a little bit about your thoughts about the ones that stand out the most to you.
Well, there's one that stands out particularly, David. I'm old enough that I grew up tending failing flaps. That was my job as a resident. Remember, I took 2 residencies. In my residency in Cleveland, in which we did extensive head and neck reconstructions all the time, and many other forms of reconstruction as well. And I spent a lot of my time, most of these patients were inpatients, and they were there for long periods of time, and I would come along and ice flaps and milk flaps and this and that, and many of them were tube pedicles, as Gillies taught us to do. Gillies' greatest mistake, the contribution he took the greatest pride in, turned out to be the most costly mistake of all in his life. He held back the development of plastic surgery by about 15 years. The first person to describe it, of course, was Filatov, the ophthalmologist in Russia, and that was his greatest disappointment, that Filatov had beat him to the concept of closing the pedicle, and he beat him by a matter of months, and Gillies was never quite got over it, but it turns out his championing of the tube pedicle held back the specialty a terribly long time. And that was because of the enormous prestige that he enjoyed in the specialty, of course. He was right about so many things. We have tendency to, when think somebody's right about a lot of things, they're right about everything, and he was wrong
Right.
about that. But that's what I was raised on my first residency, and we even had a sort of a saying that until you lost 50 flaps, you probably weren't a competent plastic surgeon. So
Right.
it was a very different thing, and it's not because necessarily Millard turned his back on that, but he wasn't, with my second residency, but he wasn't doing that kind of work except in one area, basically. He made some inroads into head and neck reconstruction, but they were limited. But his breast reconstruction, in fact, was a tube pedicle reconstruction for the lower abdomen, as described by Gillies and Millard together. And it was sort of a throwback. And at that time, wonderful things were happening. We had a guy named Ralph Gere. You remember him?
No.
The muscle guy. He's the guy who began to basing flaps on muscles. And then, of course, John McCraw put it all together, and he's been honored for this, and rightly so. Because I think it was probably, of all the things that I think back in the recent past, remember Gilly said the most important advance in plastic surgery was the development of photography, the documentation of pre and postoperative results, and he's still right about that. Without that, we had no science
Yes.
for our underpinning at all. There was no documentation. But after that, I think, and I give John that enormous credit. It was a heady time at the time, but understanding axial base flaps based on muscle anatomy, we'd had that information had offered itself to plastic surgery earlier. We turned our back on it because the people who presented it, like Menchot and others, were not in elevated positions, elevated status within our specialty. But that made all the difference. And I must say that in my second residency, I almost never saw a failing flap except for a tube pedicle reconstruction of the breast. That was an enormous difference for me. And when you think about I guess the focus of plastic surgery, I mean, if you're going to define this funny specialty that nobody understands very well except plastic surgeons, I guess, it's really caught up on the idea of tissue transfer, isn't it? I mean, it's moving something from one place to another place for some overall benefit that we can get. And so here we had, for the first time, reliable tissue transfer, and other than thin, partial thickness grafts. So that, to me, was the paradigm shift that means everything. Now, there have been some other paradigm shifts that I touch on a minute to say that, of course, the outgrowth of that was the free flap. And, of course, I think of Harry Bunke, and I think of, not neglecting our Australian colleagues, but I think of Harry as the man who wouldn't say die, who would never give up and follow this to the end. And of course, look at where we are now today. We're going to most of the great papers we're going to see later during the association are going to have microsurgical transfer of tissues as a key part of their
Yes.
of what they're going to show us. And we take it for granted now. So that was an enormous second step, but it wasn't as great as the step of understanding the actual basis of the blood supply of skin. And if I were going to mention anything else after that, I'd have to say, because I've chosen to spend the last half of my career as an aesthetic surgeon, I would have to say in that regard, fat grafting, where
Yes.
I just not quite to that level, but it's a big, big contribution. And although it wasn't started by, here we are in New York, it wasn't started by Sidney Coleman. Actually, the first modern fat grafter was Abel Shakshir down in Argentina, but Sidney's the guy that put it together.
Yeah.
And developed a protocol, he developed an instrumentation, he gave us long-term follow-up, and he deserves really all the credit. And that's for a guy who's spending essentially his whole time now in aesthetic surgery. Fat grafting is enormously important, and it also was a great paradigm shift in our ability to transfer tissues in the special environment of aesthetic surgery.
Yeah, well, it didn't have credibility till he did it. And I remember he came to Texas at the Texas Society, and I went, "Whoa, really?" I mean, he didn't even do facelifts on some of these patients. I don't know whether it was part stem cell, but it's like, and he was anal, as you know, about 1,000 pictures of everybody. And
He was held back from his recognition, though, David, for an unjustifiable period of time. I remember that the first time Sidney was able to present his material at our National Society, ASPS, which now it was ASPRS.
Right.
And it was only when it was a panel I was on, and we got him in through the ASMS, the maxillofacial. I mean, maxillofacial society.
Right.
And this was 10 years into this. Sidney was held back a long time. As you say, it was controversial. There was a lot of resistance against it. I want to think it had nothing to do with the fact that he was one of our first openly gay plastic surgeons. That may have had something to do with it. But Sidney's contribution has been enormous, and it was longer. I mean, plastic surgeons are surgeons, and surgeons by their nature.
But you said
Are
Gillies
in-the-box
held up
thinkers.
plastic surgery for 15 years
Because he was that's right.
he was so regimented
Exactly.
that plastic surgeons said, "You can't do this. Why can't you? Because nobody's ever done it before."
Yeah.
Well, that's true. I guess it's true, but not related.
Sure.
And I was thinking when you were talking, this obviously is about you, but I was thinking when I came. Remember the story that the patent office said we should shut down the patent office in 1920. There's no more inventions.
Yeah, that's right.
I thought of
Nothing else to
plastic
think of,
surgery in
yeah.
1975 when I was going to practice,
Yeah.
or 77, that we did a breast reconstruction up in Akron, and we did a skin flap, and rotated it around, and that was new, and look where we are now. You know, that was like, this is the newest thing in plastic surgery, and we've come so far.
I would say, and I'm sure all your interviewees have said much the same, we needn't fear for the future of plastic surgery. It's so damn innovative.
Yeah.
And there's another thing that's going on now that wasn't always the case in plastic surgery, is that we are attracting the best from medical school. And there was a time when that wasn't the case. We had burdensome requirements. Everybody was expected to complete general surgery and all of that. And I'm not so sure that was such a bad thing, but nevertheless, it did limit our the talent of our
Absolutely.
of our trainee pool. This is no longer the case. Plastic surgery is getting the best and the brightest, and just look at where we are now. Look at Eddie Rodriguez, for God's sake, here in New York. I'm pushing New York because this is where we're sitting. Okay,
Right.
The sky's the limit
Yeah.
for this specialty.
Well, in that regard, I would like to know what you feel your greatest professional accomplishment is.
Well, that's always a hard one, and you know,
I'll tell you if you want.
as one who's trained, who had the privilege of training plastic surgeons, I would say the ones who turned out well is probably the thing I'm proudest of, and that was most of them, I'd like to say, and I have great respect for a lot of my old trainees. I've trained some 40 or 45 plastic surgeons in my time, and of course the other side of that coin is one of the greatest disappointments are those few who have disappointed for various reasons. So that's something I'd have to answer. I'll give one example. Perhaps of all the people I trained, the one perhaps I was proudest of was Steve Kroll. And Steve I had known because he was a classmate of mine both at Dartmouth and undergraduate school and also in medical school at Harvard. In fact, we lived in the same building in Boston in Beacon Hill. But I had the privilege of training Steve after he'd taken a wrong track into ENT, and he was but Steve, was everything that anybody could have. He so eclipsed the ability of his teacher, or teachers, Scott Spear and I both had that role. He went so far beyond us, so that's what you hope as a teacher. And of course, my greatest disappointment may have been his very rash and sudden decision to end his life.
Yeah.
So that's something else I would say. You asked me to bring some memorabilia with me, and I didn't read your memos until I was on the Acela train up from Washington earlier today. I didn't look at that stuff. But I got all this regalia here on this left lapel. And I'll say that's one other thing. I'm proud of the fact that when I was vice president of what we then called the Plastic Surgery Educational Foundation, it was a broader organization that, we all have to look around for something that we want to leave our mark, don't we, all of us, as we come through any of the societies. We all put in so much time and so much effort away from practice, away from our families to get to that level in any organization, and we want to leave a mark. And the first person in the Educational Foundation who talked about the need for an endowment to support research was Bob Russell. Now, you know Bob. He was, Central Illinois, University of Illinois and all, and Bob talked about that in a very quixotic way some years before. And then Mal Lesevoy from Los Angeles, when he was the president, thought that should be his theme, and he brought it up. We should have this broad member drive to develop an endowment to support plastic surgery research in the style that Bob had thought about, and it just didn't go anywhere. All of the all of our fundraising specialists and all said, no, this won't work now. This is the wrong time, wrong this, wrong that, wrong everything. And Mal was, I know, very disappointed in that. And then my time comes along as a vice president of society, and it just happened to time out with another one of my great disappointments in the specialty, one that has left me still with a bitter taste in my mouth, and that was the breast implant business. And it wasn't just my distaste for Connie Chung and everything she represented, but what was, to me, an absolute victory of politics over science. And to me, that was very, very demoralizing. As a matter of fact, I left breast surgery over it. I had, my practice at that time was largely breast surgery, but mostly breast surgery, and I just walked away from it. Another guy did the same thing, and that was down in Atlanta. Oh, know him so well.
Boss?
No, not John, but it was Fouad's partner for so long, and he also was Rod, and he walked away from it also, and so that was a tough deal, and.
Well, I would say breast surgery's loss was facial rejuvenation's gain.
It's what now?
Breast surgery's loss. You're leaving breast surgery. Was facial rejuvenation.
Not at all.
Yes, it was.
There was a guy sitting at Georgetown by the name of Scott Spear who was just ready to go to town on it. In fact, he helped support the reinstitution, in fact, of the silicone implant and all that. But to me, I saw it as a victory of, as I say, politics over science. And it was a bitter pill for me, and it was a more bitter pill for another guy by the name of Norm Cole, who'd not been so much involved in the organizations that you're representing, the EF and the association, so much.
I interviewed him.
But no, yeah, I hope so. And Norm, my purpose then as the vice president was to get this in Norm's brain, and I decided that this was the time to do this thing, to establish a reliable funding base for plastic surgical research. And Norm was very, very open to this, because he also considered that a terrible defeat in his time, because he'd organized all of these fly-ins for all of these pay, and if anybody can organize a political action, it's Norm Cole, and it failed totally. So he was very receptive to the concept that this was something that had to be solved not by political action, but by research and science. And he put all of his effort and all of his considerable weight behind that, and of course got the thing off the ground. He was able to get so many contributions to this new concept, and it was all against the advice of all the fundraising specialists that we had. As a matter of fact, we ended up having to fire the fundraising guy for the EF because he was so opposed to it. And Norm got the thing going, and I did my little bit to help it along as well. And one of the things I did, and that's this guy sitting here, is get the Millenniac group going, which is our first sort of a legacy group, to where you leave some money behind to support it after you. And this thing up here is the is the combined logos of the EF and the endowment. And down here, of course, is the I think they call that a Millennium Fellow, because of course the association also became involved in trying to support research. That's always been a major thrust and goal of our association forever, and so I stepped up to that also. So when you ask at some point, what do you recommend for surgeons? Well, what I recommend for surgeons is to realize that the future of the specialty lies in research and development, like any businessman knows in any area. And the plea that I make is, if you don't have the skills and haven't taken the time to get the background to do research yourself, then for Pete's sakes, support it financially. And we're doing a better and better job at that, and that's an important message, and that's what all this stuff is that I just happen to have traveling with me on the train, and so I put these things on.
Well, Julia Territz has said that it was because it's kind of in line with what you say, is except she looks at it as a governmental thing. She says we have no position at the National Institute of Health. Everything runs through everybody else. So if we have a program we want to pursue, we have to go to orthopedics or neurosurgery. We don't have a representative there who can lobby, basically, for plastic surgery. And I'm talking about, obviously, her whole life has been to reconstructive. Absolutely. And so it was... and
this is so true. And that's always, we're everybody's stepchild, aren't we, in plastic surgery? And it's very hard for others to look at us and to say we want to support plastic surgeons, because our image since the early 20s has not been necessarily a positive one in American society. And with the exception perhaps of cleft lip and related things like that, we've never been able to get a hold of that, of the public, in terms of our need for research. And that was one of the realizations that drove the endowment, and it was simply this: that if we weren't going to support research, nobody was going to support research. If you can't get the plastic surgeons who've grown up and been able to embrace this specialty because of what it is, if you can't get them to support its future, how can you expect somebody else to, based on misconceptions that are society-wide? And we've lived under that ever since Humphrey Bogart portrayed a plastic surgeon whose office was over some grocery store someplace, who changed the appearance of a criminal.
What movie was that?
I'm not sure it was Humphrey, but many people played that role, about the sort of nefarious role of plastic surgery and trying to change identities and all this sort of. We've suffered from an image problem, and sadly it continues today, and it's just the way it is.
Let me ask you, and you may have answered this in some form, which has been your greatest joy?
Well, again, it's training wonderful people, and I would say that's been my greatest joy. I love the fact that, again, I'll talk about Steve, because his loss was so devastating for me, and it continues to be devastating, because we had gone back before we had a teacher-student relationship. We were colleagues with a long, long history all the way through college. So my greatest joy was seeing him go way past anything I was doing as a breast guy, and just eclipsing the heck out of me. At the time of his death, he was the #1 breast surgeon in the world for breast reconstruction. He was fully capable of doing every free flap approach to reconstruction, as well as he had the most aesthetically appealing outcomes, and his patients loved him to death, and I was so proud of him. Now that's a joy.
Yeah. Did you give any words of wisdom for future? And you've mentioned the financial donation part, but for future generations and present generations of plastic surgeons.
Well, yeah, I'd say, David, you gotta be careful. A surgery, by its nature, is a very hierarchical undertaking. We still look how Look how long the Halsted radical mastectomy held sway in the surgical community, way beyond
Yeah.
any possible justification on the basis
Well,
of
that was
scientific
argued into
data
the
at the time.
80s and 90s.
In the 50s, we already knew that women who had there was a study in Alton, Illinois, when the 3 board-certified general surgeons went to the war, and in Alton, Illinois, during those war years, 4 or 5 years, the mastectomies were all done by GPs, and they were all simple mastectomies. And then the board-certified plastic surgeon returned to Alton and resumed the practice of radical mastectomy. And somebody had the sense to look at this as a natural study and found out after 5 years or 7 years there was not 1 day difference in survival statistics. So we knew that in the early 50s, and yet the Halsted operation held sway so long. Why? Because parallel to Gillies and the 2 pedicle, because Halsted held such sway, because his name and his concept. So we're hierarchical. We tend to give in to authority figures. We tend to believe very much in, not upsetting the boat and all of that, and that's not good. That's a problem. So my recommendation to surgeons in general and plastic surgeons is don't be afraid to step out of the box. Now, when you step out of the box, you better be able to back it up with solid science, solid results. You can't be what my Lord used to talk about as what he'd call that going ape. You have to stick to your principles and all that, but step out of the box. Avoid limiting your training. Even though you think you know what you want to do in this specialty, you'll be very surprised how your career turns out. And if you limit your training early on, you'll limit options later. So don't limit your training too much. And avoid early specialization. I'm pretty specialized right now, but I didn't get into this situation until late in my career, and it's one that I sort of resisted, thank you. And I'd also say avoid, focusing on technique and having these technical menus. Oh, I can do 13 or 47 or 22 operations. That's not what plastic surgery is. Plastic surgery is principled problem solving of the kind that most of our colleagues are incapable of. And so we rise to our greatest when we engage in that based on principles, and I think that's the future of the specialty. So, contribute to the research and development of the specialty. If you can't do research or are not inclined, for Pete's sake, support it. It's our lifeblood and future.
Well, I'm going to ask you in a second about the next 25 years, or in 25 years, what you foresee in plastic surgery. But I have to tell you, and I love the name, the stomatoplasty, the rejuvenation of the mouth. What you've done, seriously, I just have to say it, that is the most amazing results. Nobody, it's like Sid Coleman with a fat grant. Nobody could change. I mean, I looked at the pictures and I said, that changes the age of a face by 10 or 15 years, and it's just creative. It's purely, it's obviously a principle of plastic surgery, but I have to give you that.
You're very nice to say that. Of course, I've focused my efforts and all recently on facelift and the related aspects, and I must say that I've come to conclusions that are not held specially wide, and I'm going to take a crack at them again tomorrow during our aesthetic symposium. This will be the 9th that we've had since Bauman Geieren started this at the association all those years ago. And I'm going to try and show the audience that let's pay attention to principles of aging, and let's look at what's really important. The mouth has been terribly overlooked in all the things that we deal with. And as a matter of fact, I make the point that among the expressive features, the things that the poets talk about, eyes and mouth, the mouth is more important than the eyes. And as a matter of fact, in most cases, now sometimes that's not the case. Individual situations may change it, but I think it's a woefully overlooked area in the field, and I think that we've turned a blind eye to the mouth, and I think we've done it because its correction is difficult, and it's often when something is difficult and doesn't seem to respond as simple measures, one approach is to just, as I say, turn that blind eye to it and not recognize it or deal with it. And I think it's a mistake. And so thank you for saying that. I think that the approach to the mouth is extremely important.
Well, one thing, there's a quote, because you kept bringing up, or you brought up principles. I read once, I wish I could say I came up with this saying, that in plastic surgery, learn principles, not methods, because the mind that grasps principles will devise its own methods. Which
You
I
said
think
it better than I did.
Yeah, it's the greatest quote, and it was actually in a orthognathic book.
Yeah.
And when I read that, I thought, boy, that's kind of about what we do. It's not regimented everything. You know the principle of blood supply. You know the principle of aesthetics, and if you defy or cross that border, people will know that because they'll see it. So tell me, in 25 years, your prediction for plastic surgery. Or specialty?
Oh, it's very healthy now. You know, there was a time when people were worrying about its survival and all of that, and you know, our history has been one of losing. What do they call it? What are the business people losing market? You know, we're always losing
market share.
We damn near lost hand. We lost all of head and neck reconstruction. We lose one thing after another, and yet the specialty is not going to run dry. Not as long as these young people, I'll think of Eddie again here, coming to mind, people who dedicate themselves into unbelievably complex tasks, like a facial transplant. And that's just the obvious example, but that's just the top of that iceberg. I think there's so many things coming down the pike, and I'm sure most of your interviewees have also talked about what's going to happen when we finally there'll be another plateau and another plateau on our unending fight against immune rejection, and as those plateaus are embraced, all of this just for plastic surgeons just becomes more and more and more exciting. And so I just think the sky is the absolute limit as long as we continue to attract the brightest people that come out of medical school. Now, there's another advantage in my specialty, and I'm going to take this opportunity to play a theme of mine. I think that the history of facelift hasn't necessarily been wonderful, and I think we've made some wrong assumptions. I think we've barked up some wrong trees. And I think that's gone on until relatively more recently. We've become more aware of the role of volume and other things. I think, and when I look back at the focus of the specialty, it's hard to understand it a little bit, but there's something that I have to say about the history of facelift. Not a single woman had a role of influence in in facelift after Madame Noel, Suzanne Noel, in Paris in 1920, who wrote a little book about the topic. This was all a male enterprise. And it was a male enterprise by people who chose not to go into other more challenging areas of science, like astrophysics. And they decided to take the easy route of medicine and plastic surgical practice. But these were all left-brain thinking males with sort of a tunnel vision. And they all had their goals.
And patriarchal.
They saw their goals, but they did it through a tunnel vision approach, and they weren't the right goals necessarily. And women have a great advantage over us in that regard, because you mentioned right brain, left brain thinking early on in this. And of course, women, by their very physical nature, by their anatomic nature, the corpus callosum in women is much broader than it is in men. This is an autopsy finding that's been accepted for years, that their communication between right and left hemispheres is much more fluid than ours, and that women don't have the abilities we have for focused tunnel vision, perhaps, as men, but they have a broader perspective, which often, is truth. And in a field like facelift, where I think there's still so many wrong paradigms, and there's so many wrong assumptions, so many wrong principles, I think that we would have clean this up a lot quicker if there had been a few women in the mix. Now the majority of people being trained in plastic surgery are women, more than men. This is going to change too. So in the aesthetic fields in particular, we're going to finally have the advantage of natural right brain thinking. These will still be strong scientific minds, but they're going to have that extra corpus callosal connection, which I think has held back our understanding of this field a little bit. So how's that making me with my with my male colleagues? Probably not so popular.
Oh, well, I guess if they're realistic, they'll understand that.
Right.
So, well, Dr. Little, thank you so much. What an interesting discussion we've had.
Well, David, it's been a pleasure.